Peripheral nerve injury. Peripheral nerve injury (PNI) is an injury to nerves in the upper extremity, radial, ulnar, median, or lower extremity, peroneal, sciatic, femoral, and tibial. PNI may include damage to major nerves, the nerve root, plexus, brachial or lumbar, and other peripheral sites. Pathophysiology and etiology. The incidence of PNI is approximately 2 to 3% in populations with multiple injuries. Males have higher incidence than females. The most frequently injured site is upper extremity, specifically the upper arm. Childhood PNI occur predominantly in the lower extremities. Traumatic head and skeletal injuries are frequently associated with PNI. PNI may result from penetration, laceration, contusion, stretch, missile, or crushing. Other mechanisms of injury include industrial accidents, stab and gunshot wounds, and motorcycle accidents. Nerve injuries are classified according to the Sunderland system, which establishes grades of nerve function on which to base recovery and need for surgery. Grade 1 indicates neuropraxia, in which the patient recovers in days to weeks and no surgery is required. Grade 5 indicates complete laceration of the nerve with guarded prognosis. Within hours of injury, the regeneration process begins with axons sprouting growth cones with a proliferation of Schwann cells. SCHWANN, Schwann cells. These specialized cells guide regenerating fibers into muscles and facilitate axonal growth. With the exception of neuropraxia, in which nerve damage is minimal, the rate of axon regeneration is approximately 1 to 2 mm per day. Clinical manifestations: flaccid paralysis, absence of deep tendon reflexes, atonic or hypotonic muscles, progressive muscle atrophy, fasciculations peak 2 to 3 weeks after injury. Trophic changes: skin is warm and dry 3 weeks after injury, then becomes cooled and cyanotic with loss of hair, brittle fingernails, and ulceration development. Causalgia, that is chronic pain syndrome. Specific to area affected: radial nerve, if radial nerve is injured, weakness in extension, possible wrist drop, inability to grasp objects, make a fist, and impaired sensation over posterior forearm and dorsum of the hand. If brachial plexus injured, difficulty in abduction of shoulder, weakness with supination and flexion of the forearm, upper trunk, or extension of the forearm, middle trunk. If lower trunk, paralysis and atrophy of small muscles of the hand. Median or ulnar injuries: sensory, if median nerve, sensory; if ulnar nerve, motor function, loss of motor function in the hand, pronation or position of thumb, paralysis of finer muscles, finer flexor muscles. Femoral: weakness of knee and hip extension, atrophy of quadriceps, absence of knee jerk, loss of sensation of anterior aspect of the thigh. Common: peroneal, foot drop, sensory loss on dorsum of the feet, difficulty with eversion. Sciatic: if sciatic nerve is injured, foot drop, pain across gluteus and thigh, loss of knee flexion, weakness, paralysis of muscles below knee. Diagnostic evaluation: muscle ultrasonography to evaluate extent of muscle involvement and assess acute nerve injuries. MRI and electrophysiologic studies such as ENG and EMG to detect site and degree of the nerve injury. Muscle imaging may detect atrophy and mesenchymal alteration of skeletal muscles. Tinel sign: tapping the axons of the regenerating nerve produces a paresthesia in the normal distribution of the nerve to determine rate of axonal regeneration. Management: microsurgical repair with tension-free coaptation using technologies such as CO2 laser welding, fibrin gluing, and ring coupling. Autogenous nerve grafts are the gold standard. Small segments of nerve graft may be placed to create a bridge to facilitate axonal and squamous cell growth. Nerve conduits connects the nerve sites, may be compressed of bone, vein, artery, silicone, or other material. Tissue expansion is used to compensate for tissue deficit. Insulin-like growth factor and acid fibroblast growth factor have enhanced regeneration when administered systematically or topically, and other factors are being investigated. Corticosteroids may be used to decrease edema. Splinting or casting may be indicated for reducing remission on the PNI side to facilitate healing. Complications: infection if injury is penetrating and site becomes contaminated. Compartment syndrome due to edema and positioning. Muscle atrophy, flaccid paralysis, and sensory deficit. Thank you.